The problem was that we also had a lot of very verbal opposition from people who weren't aware of how PAs are already utilized in a state. And I think very silly things like being told that no PA should ever be able to read an MRI. And the truth is that I often read MRIs every day in my job for a shoulder. And I could argue that I can read an MRI sometimes better in a shoulder because I've also been in the shoulder a million times. And so obviously that came with a great amount of training and didn't just happen overnight.
Welcome to the East Anchorage Book Club. I'm your host, Andrew Gray. The purpose of this podcast is to tell the stories of Alaskans of interest and importance. Today, our guest is the immediate past president of the Alaska Academy of Physician Assistants, Jenny Fayette. She is a graduate of the only physician assistant training program in Alaska, the MEDEX program, which is a partnership with the University of Washington and UAA. Prior to going to PA school, Jenny was an exercise physiologist, a high school science teacher, and a professional cross-country skier. After a decade working in orthopedic surgery, she recently took a job as a PA in breast surgery. Full disclosure, I am also a physician assistant, and my own personal experience as a PA informs our discussion today. We will be discussing a bill from the most recent legislative session that would have modernized the way PAs are treated in Alaska statute. Senate Bill 115 was sponsored by Senator Lukey Tobin, who represents downtown Anchorage. Her bill never made it to the floor of the Alaska State House and therefore died at the end of the 33rd legislature. A new and improved version of that bill will likely be introduced in the 34th legislature.
Okay.
Jenny Fayette, welcome to the podcast.
Thank you. Happy to be here.
You grew up in Anchorage, right?
I did. Born and raised. I grew up in Anchorage over by Valley of the Moon Park. I have a bunch of siblings, so a big family.
How many?
In Anchorage. I have 5 sisters, 1 brother.
And which number are you? I'm
number 3. Grew up here. My parents moved to Girdwood when I was in junior high. And so we bussed into Diamond. So I'm a Diamond High graduate. So I went my first 2 years of college at UA and then transferred to Northern Michigan University for their cross-country ski team.
Oh, you were on the cross-country ski. So you were always a cross-country skier?
I grew up downhill.
You grew up downhill. Girdwood.
Yep. And then switched over to cross-country in high school.
And you competed in college?
I did. And then for a few years after college.
Oh, wow.
So, yeah.
So what you study in college?
I studied exercise physiology, so my undergrad.
And then what did you do with that?
I didn't use it in the beginning because I skied professionally for 3 years after college. And then I moved back home and worked in cardiopulmonary rehab. So...
And did you do Junior Nordic? I don't know if y'all have Junior Nordic in Girdwood.
I grew up in doing Mighty Might. So I actually grew up as a downhill skier. And so I raced in downhill until my parents got divorced. And then we didn't have downhill teams in Anchorage. So I moved it over to cross country. So I was older than Junior Nordic.
So you hadn't really cross country skied until you were a teenager?
Not at all.
And was it an easy transition? And the reason I bring that up is stupid parent mistakes, but I messed up. My son wanted to do Devos. I didn't pay attention to my email. I missed the registration. I registered it for Junior Nordic, and A, he's furious because he's like, I don't like that. And B, I had parents be like, well, it's going to really suck for him because he's 11 and he's only done downhill and he's going to suck. And okay.
So what I'll tell you, what I think is really interesting, I made all my kids learn downhill and cross country because I think that no matter what he does, he's going to be better with having both of those skills. But I was on E-team my sophomore year in high school, and I had come from a downhill background, and I was pretty competitive in downhill. But all of a sudden, I didn't have the money to continue because I didn't live at home anymore. And so I just got thrown into it. And I totally was on E-team, and I was like, man, this is
like
awful.
E-team, the worst team? Like
A, B, C, D, E. Yeah.
The slowest of the slow.
The slowest of the slow. Like the group of girls that I was tight with, we would make it to like the shortcut area. And that was as far as we'd make it. And then we'd get back on the bus. Like it was really bad. But at some point, we had these older skiers that were really good, like 2 years older than us. And so they were seniors when we were sophomores. And they were really nice to us. And so we were like, oh, skiers are cool. And so then my friends and I started training. And by my senior year, luckily at state, I won the race. Nobody believed it. Even my coach was like, hey, don't get too excited. We should probably check these results. And it was really like, it was funny. So it turned out that I did win the race, but I was beating these people who'd grown up in junior Nordic that had families that were skiing forever. So it was weird. I didn't apply to any colleges, but UAA came, put a little thing on my ski bag at state meet and was like, come ski for us. And that's how I went to college. Like I wouldn't have ever gone to college if that didn't happen. So I always tell kids it's not too late, especially if this kinesthetically, they can figure things out.
He got really irritated about that mom saying that he was going to have a huge learning curve because he was like, it's not like I've never cross-country skied before. He has cross-country skied before. It's just he prefers downhill.
Yeah. The parents want to believe that. They want to believe that all the money that they put their kid in for Winter Stars and APU, I think that was the hardest thing for a lot of people. And I actually became really good friends with Denali Kemple, who was like training hours and hours at that point. And I'm sure for her, it must have been disheartening to have this like stupid girl who didn't even really know how to ski come and do it. In cross-country skiing, if your son decided at some point, he really wanted to become a good cross-country ski, his downhill background will help so much.
How did you decide that you could be a professional skier?
I had graduated with an exercise physiology degree and then got offered a spot on an all-women ski team out of Sun Valley, Idaho. And I professionally skied because that was my official job title, but I also held 3 other jobs while I was doing that. That was long before cross-country skiers got their own cars or were really performing high at an international level. So there wasn't a lot of funding, but...
Yeah, how does that work? Do you have sponsors? Do you win money for doing races or...
Yeah, once you're out of college, you could accept money when you won races, and they had a sprint series that went around that gave a little bit of money. The rest of the races didn't really give a lot of money. The all-women's team was sponsored in Sun Valley by a bunch of different people. So like Steve Miller from the Steve Miller Band was one of our sponsors. He put on a concert for us that paid for us to go around Europe and race for months at a time. And then Arnold Schwarzenegger and Maria Shriver were sponsors. So we got lucky. There were a lot of people who supported cross-country skiing in that community.
Did you enjoy those 3 years?
Oh, I loved it. I loved it. I would have done it forever.
Why did you stop?
Yeah, so I overtrained. I got really sick. This is what reinforced me becoming medical. I saw a lot of doctors that couldn't figure out what was wrong. And I'd gone from being one of the top 10 US athletes in cross-country skiing to being like not even on the charts. So a 12-year-long goal for me came to a close because I couldn't perform anymore. So yeah, so I had an early retirement. I came home and had some awesome friends who got me a really great job in cardiac rehab. And I started using my undergrad at that time.
Yeah. What did your job as an exercise physiologist look like? It's different than physical therapy, or I don't have a good image of what that job is.
Yeah, we work alongside nurses in that job. So exercise physiologists and nurses are interchangeable in that job. So we would do rotations up on ICU and PCU. And so both in cardiac and in pulmonary. And basically just watching, you learn a lot about their heart rhythms, blood pressure, all the risk factors to cardiac disease. And so a lot of teaching involved.
And teaching the patient?
Yeah, we did a lot of weight management. I taught weight management for about 7 years as a night class. That was in addition to what we did for cardiac rehab, but educational classes every day. So they came to exercise, but then they would also sit through lectures. Did that for 8 years before I left. So married military and left Alaska for a while.
And moved to Japan?
Moved to North Carolina first, and then Japan after that. Yeah.
You worked in cardiac rehab in Japan as well?
No, I just got my master's in education and then worked as a teacher in Japan for a while, and then moved back into exercise physiology with the Health and Wellness Center there in Okinawa. And then we moved to Colorado. So I worked in Colorado for a while for the Health and Wellness Center at Peterson Air Force Base, and then was a flight commander there, and then got accepted into MEDEX program here and was able to come home and do PA school.
When did you first learn what a PA was? And
I remember the exact moment. I was actually working cardiopulmonary rehab up on PCU at Providence. And I saw one of the cardiologists, and they were mentoring someone before they went into a patient room. And I remember listening to what they were telling the person. And I was like, I know all that. Like, I've been doing this for 8 years. Who is that person and what are they doing? And then like maybe a month later, I saw that PA going into the rooms by themselves. And I was like, wow, that's really an interesting career. And so I researched it and asked a bunch of people about it and had it in the back of my mind as maybe a pathway that I could take when my life settled in some ways.
Because you have kids.
Yeah. Yep. I have 3 boys.
How old are your boys?
My youngest is getting ready to turn 18 next month.
Wow.
So huge changes for me. And then I have 2 that are in college right now, 21 and 18.
You saw this PA on the floor at Providence and got interested and researched. What is a physician assistant? I mean, I've had lots of different ways of describing it. I say the substitute physician, like substituting for the physician. And I've said that it's like I went to medical school, but I stopped with a master's degree. And in exchange for that, I have a collaborating physician for the rest of my career. That's...
Yeah, absolutely. And I think that's really true. Yeah. So a physician assistant is, and it's changed over the years, but you basically get a quick kind of fire hydrant education in the medical model. And then you work alongside physicians and nurse practitioners, and you get to fill whatever role it is in the organization that you're in. And we have surgical PAs, we have specializing PAs, we have family practice PAs. You essentially are seeing patients. You're diagnosing them and treating them. And I've recently changed my specialty. My prior job, I was an ortho for 10 years, and I got really good at doing my own things. And so I ran my own patient load, and I reviewed my own MRIs, and I treated my own patients for most things. I also worked in the surgical aspect, so I was assisting my surgeon as well. And it becomes a little bit more independent the more experience that you get. But now I'm back into a new specialty, and I think it's the same thing. Like, I have my basic knowledge of medicine that I learned in my physician assistant studies. And now I'm just learning all the specialty
what's
from the physicians. I'm working in breast care. Oh. So yeah, breast care and surgery right now. So
bouncing back, so you did the MEDEX program. What is the MEDEX program?
Yeah, so the MEDEX program is through the University of Washington. They partnered with University of Alaska Anchorage. They actually have been partnering with them since 1971. That was the first time that PAs were brought into Alaska. So they brought 7 PAs to Alaska during the pipeline when there was that boom. And so University of Washington and UA have worked together for a really long time. And MEDEX has a bunch of campuses, but one of them is in Anchorage with UAA, and they work to try to get people who are familiar with Alaska to do their studies here, do their clinical clerkships here as well, and then go out into the community and practice with the doctors and the providers that they've already become really familiar with.
So you graduated from the MEDEX program in 2014?
Yep.
And you took your first job in orthopedics?
I did, yep.
And how did you make that decision?
Yeah, interesting. There were no jobs. I did a rotation out in Naknek. It was my last rotation before I graduated, which was an amazingly incredible teaching rotation. But when I came home, all the primary care jobs were gone. There were a whole bunch of ones from A&MC, and so a lot of my friends got hired. And I was really scared because there were no jobs anywhere. So I actually wrote 5 letters to 5 of the rotations that I did, that I really liked the atmosphere and the practice. And I said, hey, if you ever have a job opening, I'd really be interested. And I got 5 letters back, and I did 5 interviews, and I got 5 job offers. And the orthopedic job at the time promised a good salary so that I could keep taking care of my children, pay my mortgage, and also a good life-work balance.
That's what you were promised. You were promised a good life-work balance.
Yeah.
Was it actually a good life-work balance?
Yeah, no. It's medicine. And so we were just busy all the time. But yeah, I think there was a point where I calculated my call, and I was taking like 9 to 14 days of call, and not necessarily always going in, but always just available. It never stops.
My very first job, I took call. And I'm not sure people understand that when you're on call, even if no one calls, it sucks.
Yeah, absolutely.
Because you're on edge. You're thinking that at any moment you will have to go into work.
Yeah.
And it's difficult to sleep.
Yeah.
You're listening for your phone while you're asleep.
Yeah. I was a single mom too. And so it was a great job and I loved what I was doing, but it was just a lot of having to have a backup care for my
What would
kids
you do if you got a call at 1 a.m?
Yeah, I was super lucky because I had a niece who was in the military and wasn't making very good money. So she came and lived with me. And so I had her as my backup. So I was extremely lucky to not have to pay for that extra childcare. But yeah, she saved me a lot.
And did you get calls at 1 a.m. to go in?
Oh, yeah, absolutely. Yeah, quite often.
So your practice was covering an ER?
Yeah, and we took an EMTALA call, so city call, and we were hand and we were microvascular at that time. And so the surgeon I was working with was one of the few people who did microvascular surgery. And so pretty much we were on call anywhere in the state. And he was called even when we weren't on call.
Can you explain what a microvascular case would be?
Yeah, anytime someone hurts a nerve or a vessel in their hand and it's something more than what a general surgeon could take care of. They actually sent me to training at the Mayo Clinic and I got to replace the femoral artery on a rat. And so I kept my rat alive. I was very happy about that. But yeah, so it's just a lot of surgery that you do under loupes or microscope. So
I'm sure you learned a lot.
I did. It was a great experience.
And my understanding is that you had an agreement with your doctor that you guys were going to work really hard, take tons of call for 3 years, and then you would back off and just do more of an outpatient practice.
Yep. That's always the best intentions are set. I was just hitting 3 or 4 years with him. And that was when I decided that maybe it was time for me to go to a little bit smaller organization where I could spend a little bit more time with patients. I also grew up here. So being able to spend as much time with my patients as I need.
Because you would have patients that you've known before. You'd have like teachers from school. You would.
Absolutely. Yeah. That's pretty typical in Alaska is that you're treating people that you know on some levels. Yeah, it's hard to do that in 5 to 10 minutes for an appointment. And some of the bigger organizations that we have, that's just the way they're set up. That's the way it has to go to get all the patients through. And for me, I just found out that I like the smaller clinics and I really appreciate a collaborating physician that allows me to spend as much time as I can with the patients.
So that's 10 years ago when you took your job in ortho. Yeah. Can you just give us like a ballpark when you said it was good money? Like how much does a PA make?
They make us sign lots of things that say we can't say that. I would say that in Alaska, the average, we're around 120. And then depending on your experience as you go up, that changes. So there are organizations that start much lower and there's organizations that start much higher. But I think that's a pretty average. If we did it by hour, it would not be that much money.
You take all the time. But at the VA, I made about 145.
Oh,
145,000 a year, and I didn't have to take call. And that's
nice.
That's a publicly available number.
Yeah.
I know nurse practitioners, because they're on a different pay scale at the VA, made more than me, even though we're doing the exact same job. Yeah. But I will say that I always give advice to a brand new PA that your first job is not your last job. And a brand new PA is not the same thing as a PA who's been working for a few years because it's modeled as an on-the-job trained profession.
Yeah.
After you've seen 1,000 patients, you don't ask for help all the time. You learn how to do this because you're doing it all the time.
Yeah. And that's the beauty of that relationship, that collaborative relationship in the beginning. And it's so ingrained, that collaboration. And I always think it's really interesting. We really focus on this independent practice when we talk about practitioners in Alaska. And the truth is no one ever really is
independent. No one's an independent practice.
And so I like the term full practice authority because I think that's really more accurate to what we all do is we practice to our education and our training. And we know when we don't know and we need to call in someone. And I think that's the relationship that collaboration becomes where you can really help out. You get to a point where for me in surgery, I knew exactly how my surgeon was going to treat something. And so I could 98% of the time, I knew what he was going to do and I could lead that in. And for us, it was a really big avenue to get patients in sooner and kind of more streamlined to get the care that they needed. And I've worked in a couple different places over the last couple of years, and I think there is a really difference in the way that people utilize their PAs. And some of that is, I think, just because people aren't really familiar with working with PAs. And as people establish that, learning how to really use us to our full educational background, I think, is really important. And that's something that I see as a mission in Alaska, is to start to get people to understand what our education is and what our training is, because it's not a small amount. The MEDEX program, you have to have over 2,000 hours of paid clinical patient time before you can even apply. And then while you're there, you get another 2,000 plus, and you do your clinical rotations for a year. And I think that when we look at that and we see how can we utilize that, we have this assistant in our name. And so people really assume that we are assistants. And I think that we are providers. We do offer an assistance to help in just like any other provider would, or even another physician partner. I think that as we learn to do that, we increase access to care everywhere in Alaska.
I did my PA schooling at Baylor College of Medicine in Houston. Houston is an enormous medical complex of 40 different hospitals, and there are 2 PA programs basically happening in that vicinity. My PA program, I'm training with the ND students. We're doing our rotations together. It's baked into them that they know that I'm hearing the exact same explanations that they are, that I'm writing the exact same notes that they are, and that I'm doing the exact same exams. So they know when they get onto the real world that the PA next to them knows a lot of the same stuff as them because we did the training together.
Yeah.
When I went to work in California, it was a very similar experience where PAs were really utilized at the very peak of our scope of practice. Like we were really being maxed out. Alaska is not there. And I think part of it is that there aren't as many PAs and they don't have that exposure.
Yeah.
And so I think through no fault of the physician, I think some of them don't have as broad an understanding of what we can and can't do.
Oh, yeah. And I think, that's what we've run into, especially with legislative stuff. We've really run into this kind of misconception of what our training is. And I was lucky because the health and science building at UAA that the MEDEX program utilizes is right next to the WAMI program. And so I had friends that were in WAMI at the time that I was going through it. And so we were actually able to set our syllabus side by side and look and see and say, hey, we're covering the same information, the same topics. And I think that's something that sometimes is not really out there. I've heard people say, oh, you can have an English degree and be a PA. And the truth is, you can have an English degree, but you had to have a lot of other experience in between.
You basically had to do the same prereqs as medical school.
Yep.
Take it from somebody who actually got their bachelor's degree in English and then went back to school.
My best friend did that
to do all of their prereqs for it. I started PA school in 2010, but I went back to start my prereqs in 2008, and I was basically back to undergrad full time for a couple of years to do all this prereq.
I had the same experience because I was over 10 years out. I went to PA school as an older adult, not the oldest in my class, but I went as an older adult. And with MEDEX, you had to have those classes within 5 years. So I had actually taught high school anatomy and physiology, and I had to go back and take it because those core things had to be within 5 years. And I think sometimes that gets lost when we start going, oh, a PA program is just 2 years. And I think that's a misconception.
Bouncing back to talking about new grads. So the point that I try to make with new grads is that you need to find a collaborating physician who's willing to teach you. And that is worth way more than any salary. So if you find a great collaborating physician who is willing to work on your notes with you, work on your exam with you, teach you how to see patients, diagnose them, and treat them, I mean, take that job.
Absolutely.
Take that job.
Yeah.
Because it is absolutely true that as a brand new PA, you are not worth as much as an experienced PA.
Yeah. I got lucky because my first 3 surgeons that I worked with were amazing. Like they taught me how to read an MRI. The things that I learned underneath them, I think really are what made me be able to, when I left a place, I had patients that went with me. I was lucky to have a good paycheck at the same time as having a good surgeon. But I have recently left a job that I felt like I was never going to become a good PA at because they just didn't have the time to train me in the way that I need to be trained. And you can pull the books up and you can learn everything that you need to learn. But I think that the practice of medicine is very different than books. And so I think that that knowledge that I could gain on the side while I was doing that has to be supplemented by the mentorship that you get in those positions. And my most recent job, I 100% chose because the week that I shadowed the surgeon before I went to go work for her, I really paid attention to how much she was willing to teach me and talk to me and spend time with me to train me. And 100%, that was what made me choose that job, because as a seasoned PA, I know that's how I get good. That's how I become the best PA that can offer the most and the safe and most knowledgeable care to my patients. And
that said, I'll just point out that as an ortho PA working in surgery, doing microvascular repairs, that your skill set is extremely high and well positioned to work in any other surgical specialty, including breast surgery. And so in a way, like they're getting an enormous benefit by somebody who I'm sure can sew well. So you may not have worked in breast surgery before, but you worked in surgery.
Yeah. And absolutely. I think the majority, and we talk about this often, there is a huge steep learning curve just on patient care alone. And I think whether you're a PA or you're a nurse practitioner, you have that still steep learning. And once you learn that part, I think in the first couple of years of doing patient care, the rest can come, and you know where to find your answers. You know who to call. My list in my phone is so big of every doctor or PA or nurse practitioner that I call when I have a specific thing that I don't know what to do with a patient. And that's the beauty of medicine. And that's really the beauty of Alaska medicine, is because you wouldn't last in a practice if you didn't know who to
you have to
make those calls and
phone a friends like you've got. And I mean, and a lot of times it's texting.
Yeah. And that's normalized for PAs. I will be very happy when all of medical, when that's normalized, that if you don't know where you're going or you don't know how to get that, you pick up the phone and you call somebody. Right. And I think to some degree, we've been lucky as PAs to just have that normalized, as that's okay. And I specialized in hand for my first 4 years and then hand and shoulder for the next 6. And I think the really interesting thing is I had all providers calling me. I had doctors calling me saying, hey, I got this thing. Can you look at this picture? Can you look at this x-ray? And I think that's the beauty of time. You get to where you're like, okay, I know these things and I can help with that. And to be able to continue to do that, our basic education is general. And I'm reboarding right now at my 10-year, and it's all general medicine. And the beauty of that is that I get to keep all those things up, so that I can actually increase access to care anywhere where I work. And I have seen that a lot when we have people who come in from rural areas and they're only in town for one day. And there's a lot of things that as PAs, even if we work in specialty, we can help out with that. And we can consult a friend and help them get seen that same day. And all those things are just parts that I love about the PA profession.
One last thing I want to say, and then I want to talk about your work as an activist for the PA profession. But something I'll never forget as a PA student, it was a farewell lecture from a physician who had been one of our professors. And he wanted us to remember that we must do work that is better than the physician. And the reason why he was saying that is because we will be scrutinized in a way that a physician won't. Our notes will be read more. Our diagnosis will be questioned more. Our treatment plans will be scrutinized in a way that an MD wouldn't, simply because people assume that we may not know what we're doing and are going to always be a little skeptical of the care we're providing. And the only way that we can survive is to do better than. And I throw that out there because a very common way of referring to us is mid-level providers. And we try not to use that term because no one wants mediocre care. No one wants the wrong answer. Everyone wants the correct diagnosis and the correct treatment plan. Yeah. Everything I do needs to be right.
I love that. I think that's what my whole career has made me stay late and read things extra and research what I don't know. And I've always said it when I do a lecture for the MEDEX program. One of the things that I will always tell them is I'll say, hey, you need to do whatever you need to do. Even if you have the best doctor that you work with, the best surgeon, you got to make those patients be just as happy seeing you. And I think that's one of those things for me that it's always been my challenge. I've come into 2 different jobs where people said, nobody wants to see my PA. They only want to see me. And I just am spread too thin and I can't do this. And so in both those jobs, it was my goal to say, hey, I want them to be like, hey, I want to see Jenny. And that doesn't always happen, but the majority of the time as a PA, if you give that extra amount of time and you put in that extra amount, you can give them excellent care. And that's what we aim for. And that's what should be the goal of every PA out there is that their patients are just as happy.
Hey, I want to dispel one more myth about PAs. And I don't know why it bothers me, but people will often say, I choose to see the PA because they spend more time with me. They have more time to see their patients. As from your first job in ortho, that's not always true.
Yeah.
It's, in my experience, working primary care, working ER, working urgent care, I had the exact same allotment of time to see my patients as a physician. No one gave me extra time to do my job or to do my work. I just want to push back a little bit on that because when they say, oh, you guys are given more time and you spend more time. If we're doing that, like it's at our expense in some way. We're paying for it later. We're staying later. We've got to write the same notes in the same way.
Yep. Most training for PAs, they spend a lot of time on your physical exam and your patient care and how you interact with your patients. And there's a big proponent in every school for psych as well. And I think that part of that is that we really are taught to listen to our patients. One of the best things that I ever was told by a mentor when I was in PA school was that if you just listen to your patient, your care is already 95% better because of the way our health system is set up. And so the more time that you can spend listening and then putting together the care of the visit, the better off that's going to be. And I think PAs are just trained to listen. And that's such a huge.
I agree with you. And there are lots of doctors who listen really well too. I mean, my best rotations were with amazing physicians who modeled basically that your diagnosis is going to come from the history. Absolutely. Like if you really listen to the patient, you're getting the diagnosis. I'll tell you a really quick funny story from my last patient last night. So urgent care last patient is no one's favorite because in general, you want to get out on time, but there's always a patient that comes in and you can just see from looking at the clock that there's just no way I'm going to be able to see this patient, do my note, and get out of here on time.
That happens at breast surgery too.
And this patient comes in and they get roomed and I ask the MA, I was like, so what's the cheek complaint? And they're like, ear pain. And I was like, when did it start? And they're like, 1 hour ago. And so you can just see this look on my face of, oh, like no one has an ear infection that suddenly started 1 hour ago.
Yeah.
I'm going in there with a bad attitude, prepared to give a little lecture on how no one gets an ear infection in 1 hour. But you start talking to the patient. You start listening to what they're complaining about. And I'll just jump to the chase. It was a TMJ issue, temporal mandibular joint dysfunction, probably brought on by stress and grinding the teeth. And first time this has happened. And I remember being like really excited in the moment, being like, oh my God, this makes total sense. I can help you. Let me print something off for you. And being excited and hating myself for having that terrible attitude.
Yeah.
You know?
Yeah. And I think it's hard. I look at my job right now. I go in at 7:30 and I am working until 4:30 nonstop, sometimes no lunch break, just so that I can spend as much time as I can with my patients. And we do that because it is exciting and because we do have the knowledge to help them. You do also get tired and you get burnt out. And I think that happens for all providers. But I feel like PAs aren't really allowed to feel that way because they're not doctors and we're not doctors. But everyone in the medical system right now is taxed. We don't have enough medical assistants. We don't have enough office staff. We don't have enough nurses. We don't have enough providers. It's just all the way around.
So you are the past president of the Alaska Academy of Physician Assistants.
Yes, I am.
But I just want to explain for people that means that you still have an active role. The model is that you have the president-elect, the president, and the immediate past president, or what is that the title?
Immediate past, yeah.
Immediate past president. And so that when you run for president, you're running to be president-elect for a year, where you're basically shadowing the president.
Yeah.
And then you're president for a year. And then you continue to do advocacy in that third year, where you're basically shadowing the president. Yeah. And then you're president for a year. 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 because it is a official role to be immediate past president.
Yeah. Yeah.
So tell us a little bit about your involvement with the organization and why you decided to run for president. And
Yeah. So I got involved with this board 12 years ago as a student. And I took the position because I had 3 young children and I was going through PA school. And at the time, I had a husband who deployed all the time. And I decided I wanted to do something for the profession because I know the importance of that. Exercise physiology was very similar in that way. But I took it because it was a 1-year commitment and every other position for 2 years. So I was like, oh, I'll be on this board for a year and that'll be good. And then the year I was a student, they decided that was the most involvement that they had from a student. And so they made it a 2-year. And then I don't know where the next 10 years went, but I've done just about every position on that board. Before I ran for president, I started getting involved in the advocacy part of it and legislation. For PAs, there was a lot going on with modernization of our profession, and I decided that the best difference I could make with that was from that position. And I ran, and I ended up getting the position. During that time, a lot of things changed for PAs. A lot of kind of crazy events happened that made me continue to stay involved in other realms at this point. But
can you talk about the issues with the way physician assistants are currently treated in state law in Alaska?
yeah, nationwide in the 70s, late 60s, early 70s, when this profession
Was born,
yes. It was a certificate program. And now it's a master's program. There's a lot of training.
And I just want to say it was Navy corpsmen coming back from Vietnam who had basically been medical providers on the battlefield who came back to the States with all this medical education that they had learned in the trenches, literally, but no way to use that. There was no way for them to show up at a hospital and be like, hey, I know how to do all of this stuff. What can I do here? And so it was created as a streamlined medical training so that they could use their battlefield knowledge to have a profession.
Yeah, absolutely. And in that time, legislation was set up and things were put into place for that to have a lot of oversight, just because there wasn't a lot of development in the programs at that point. And a lot of places, Alaska included, our medical statutes were all developed in 1970, 74. And since that period of time, things have really changed in the medical in general. And so nationwide, it's been a thing. Hey, we need to push to keep our profession relevant. And so we started that in 2020. We started that kind of process talking with the State Medical Board and the Alaska State Medical Association, both which include PAs. We started talking to them about modernization. And that was really the core of, hey, we're going to start this in motion. And in 2021, there was a State Medical Board working group that was developed to start those regulations.
You can correct me if I'm wrong here. Part of the problem is that we just don't appear in a lot of statutes. And therefore, we're really 100% governed by regulation.
Yeah. Everything about our career is placed within the regulations of the State Medical Board. And so our statutes identify us as physician assistants that work under a supervising physician. And they require us to follow all of the medical regulations by the State Medical Board. But they do have a specific section in there that is just to tell the State Medical Board, please regulate PAs and what they do. And, in the 70s, that made sense because it was a new profession. They didn't really know. They really needed a lot of close oversight, not knowing how that would incorporate. And so we worked on this document for months and months with the State Medical Board, and talks came to a close. And we were like, okay, we're going to all sit on this and think about it. And then a few months later, a document was presented by the then chair of the State Medical Board. And it was actually more restrictive in ways that would have caused
clinics to close.
Clinics close, yeah. And especially in rural Alaska, it would have made PAs have to come back to Anchorage before they could actually practice out in the rural areas where they were practicing. And so it became a very big deal. We were able to really rally a lot of important people, doctors included, to get everybody up and aware of what was going to happen with those changes. And so they ended up voting them down, which was very much in the benefit of all patients and providers and Alaska in general. And that during that process, before they were voted down, I think PAs really started to realize that we are not in the statutes and we are in the regulations. We have a couple month timeline of how quickly someone new to that medical board, and that medical board is all appointed, so it can change at any time. And that's basically what happened, is it very rapidly changed. And I don't think the chair was very familiar with working with PAs, so it didn't really understand the PA process. And that was how quickly our whole profession could be changed in the state. And I think that really opened us up to how vulnerable our profession is. And so that's when we presented a bill to get included into the statutes. And
basically so that we would have a baseline right to practice regardless of who happened to be on the board and what the whims of the regulatory board. They couldn't take away our right to practice medicine.
Yeah.
And that was the fear, is like realizing that this board could just decide that the way PAs have been doing it in the state for decades is no longer allowed.
Exactly. And we know in our statutes, providers are MDs and DOs and podiatrists. PAs are not established as medical providers. And those are the 4 professions that fall under our state medical regulations right now. And that was the key of our bill. It was, I think, mislabeled scope of practice. And so it caused these arguments that kind of happened that really had nothing to do with the bill. One of the main pillars of that bill was to get us recognized as medical providers, to be able to have our qualifications and what we do all set into those statutes, not into the regulations that can be changed so easily.
And that bill, SB 115, passed the Senate with an overwhelming majority, did not make it to the House floor. And because this was the second year of the 33rd legislature, everything died at the end. And you'll be starting over this year. I just want to point out, though, not starting from scratch. Many of the legislators who were here last year will be back next year, will be familiar with this bill.
Yeah. And I think, one of the things, and I think you always learn in these processes, and I've learned a lot because I'm not a political person. It's been a steep learning curve. I think one of the big things is Alaskan language is very specific. And I think that one of the things I don't know if we realized putting the bill together was how some of the language we used was national language, because this is a national concern everywhere. And what I hope that we've learned in that process is that if we integrate it into Alaska language and Alaska statute language, that it becomes more apparent that we're not trying to change what PAs do. We're not trying to increase our scope of practice. What we're trying to do is be recognized for what we're already doing within the state in our statutes, and to keep that safe where we're at, and then be able to be regulated just as the other medical providers are regulated by our state regulations. So not as a separate category. And we've already updated some of the parts where we're already updating and recognizing that. We just haven't done it in our statutes.
It's difficult to talk about this without getting in trouble. You have to be very careful about how you say it. But the bottom line is, what we want is for the way we practice to be recognized as the way it's supposed to be. And I think the major pushback is people who think that we're asking for more than what we have. We're already doing this. We've been doing this for decades in Alaska. I will speak frankly, I work in an urgent care. It is a single provider clinic. That means that when I am working at the urgent care, I am the only prescriber in the clinic. I'm the only one in the building. Yes, I can call the owner of the clinic, who is an MD. I can call him and ask a question if I need to.
Yeah.
That's
Yeah.
a very rare occasion.
Yeah.
Most of the time, I am seeing my patients, doing my notes, treating my patients by myself.
Yeah. And
I want the statutes to say that's correct, that's allowed.
to know that's a job that you're going to hold
Yes.
3 months from now.
That they can't change the regulations and say that what's happening at that clinic can't happen anymore.
Yeah.
I'll tell you something. The clinic would shut down.
Yeah. Yeah. And I think that's the kind of misinformation that was thrown out there, is that it was going to be this huge change to what was already going on. And there were some levels of it. We introduced a pathway to have that collaboration plan no longer have to be filed with the state. And then we also recognized a pathway for it to go away. And I think that those were both something that could keep us with parity for other providers that are in this state right now. But that was seen as we were asking for something different than what we already have, and we really weren't changing it. The problem was that we also had a lot of very verbal opposition from people who weren't aware of how PAs are already utilized in this state. And I think very silly things like being told that no PA should ever be able to read an MRI. And the truth is that I often read MRIs every day in my job for a shoulder. And I could argue that I can read an MRI sometimes better in a shoulder because I've also been in the shoulder a million times. And so obviously that came with a great amount of training and didn't just happen overnight. But those were the kind of arguments that we had against this, like what would you do if your collaborator wasn't sitting right next to you? And the truth is that our collaboration is not only with our collaborating physician, it's also with every other physician that we call and consult with. And that, I think, was the misinformation that happened in that small amount of time.
Again, treading into risky territory. But I think one of the things that happened was that some doctors groups were mobilized to call the legislature, email your representative. And I think they were given some talking points. I got the emails saying that patients would die if this statute were to be changed in this way. And I would reply to those physicians and say, hey, I'm a PA. They did not know that.
Yeah.
And my experience is different than yours. We're already doing this and patients aren't dying.
Yeah.
And the response that I got back, and it was more than once, was, and of course, it's like they realized that they probably offended me. So they're like, hey, I just want you to know, I have PAs in my practice and I love them.
Yeah.
And so it was this weird response of, I love the PAs I work with, but I believe that there's PAs out there who shouldn't be allowed to do this.
Yeah.
And so I'm going to create restrictions that will hurt the PAs that I know are doing a good job, just for this abstract fear of what might be happening somewhere else.
Yeah. And I definitely saw that a lot. And I think there was a lot of that fear for surgery. And that was one of the points that I tried to really put across there, because I think we had 30 surgeons send in things that they were not okay with PAs becoming surgeons. And even with that, the pathway to that full authority of practice and not having a collaborative signature for a PA, even in surgery, means surgery assist. I am not becoming a surgeon.
Right.
I am becoming proficient in surgical assisting. And so I think that whole idea that PAs were going to be setting up their own shop and doing cardiac surgery and orthopedic surgery, I think scared a lot of doctors. And so my hope in moving forward with this is that we can get a lot of education out there about what we currently do, what our education is, what our qualifications are. That's something that we actually want to have written into our statutes because they're solid. And I hope that we can get a lot of that out there so that the scare tactics that happened in the last session don't stop us from increasing access to patient care. And that's,
And I think I heard you make the point before that the whole idea of a PA performing surgery independent is not what the statute was doing.
Yeah.
But B, if you just think it out, what hospital is going to give a PA sole access to an operating room or a surgical center? And then furthermore, how are you going to bill insurance for being the lead surgeon as a PA? There's no mechanism for any of that to play out.
Yeah.
on a number of levels.
Yeah. And I think that's why it's an interesting scare tactic, because there's so many checks and balances in place. In order to be a surgeon, you still have to have a residency. So the hope is that we make the language a little bit easier for people to read and understand what the full intent of the bill is, and get a little bit less caught up in the can a PA draw labs, can a PA read labs, things that we are already doing fully.
How could you treat your patient if you didn't interpret the labs?
Yeah.
I mean, it's just,
But I think the big thing is that there were people who were not actively working with PAs and didn't recognize that our training is based on assessing the patient, diagnosing the patient, treating the patient. That is all within our full practice authority. And I think that's my hope, is that we can move it away from some of these arguments that have been put out there that are not really accurate to what we're trying to do.
So what's your vision of what our practice should be, what it could be? Like,
in the 80s, we gave full practice authority to nurse practitioners. And we have seen an overall increase in access to care through those nurse practitioners. And things happen, bad things happen with MDs, they happen with DOs, they happen with podiatrists, they happen with PAs, they happen with nurse practitioners. But overall, the increase in access to care that we have done through that to get patients seen and have safe, effective care. And what my hope would be is that we can recognize that same thing with our PAs that have also been in this state practicing since the 70s, and doing that without detriment to our patients or safety or quality of care. My hope would be is that we can have that recognized and find a pathway that gives us parity to the other providers that we work with in the state of Alaska.
when I started work at the Alaska VA, I was the only PA working in primary care at Anchorage at the time. There were several nurse practitioners, and the lead physician who was in charge of hiring me said, "We don't usually hire PAs because we don't have time to help you. And nurse practitioners have independent practice authority, and so therefore they don't need help." I was, of course, offended because I'd been practicing for a while. And so I was like, it's not like I'm going to be asking you a question every other patient. So I was really excited to prove to him that I knew what I was doing and that I wasn't going to need extra help. But what I found was that there were brand new nurse practitioners who should have been asking questions, but felt reluctant to ask questions because the assumption was that they were fully independent.
Yeah.
And
Which no one is.
No one is. No one is. And it was a doubly bad scenario where they were basically not hiring PAs because they believed PAs couldn't work independently. And then also hiring brand new nurse practitioners who really needed to be working with experienced providers. They needed to be able to talk about patients and walk through things and in a way that every new provider needs.
Yeah. And I think that's something that we lose so often, is that in those first 2 years, if we could normalize the ability for any provider when they start to feel free to ask questions, there's no dumb question. And so being able to collaborate with everyone that you're working with, normalizing that would be such a great thing for medicine in general. Mm-hmm. It's just to say, hey, we all collaborate. We all talk with each other. We consult or collaborate, however we want to call that. We're all doing it, and we all should be doing it. And as people specialize and get out of certain areas or go into other areas, that's why that has developed. That's why residencies have developed. There used to be a time where there were no residencies. And so I think the idea of people going and working in an area and then becoming efficient in knowing their full practice authority in those areas has always been the way medicine goes. And so I would love to see that in Alaska, to see that kind of change. And so hopefully we do see that at some point. So,
hey, last question. Do you have a story of patient care that gives you the reason why you keep doing this?
Oh, gosh. That's a great question. This is actually from being a student. And one reason why I always will feel comfortable asking questions, I was observing with one of the doctors in my mental health rotation, and I was sitting behind the patient, and the doctor was talking to the parents, and the patient was nonverbal. And I was looking at the back of his head and I was like, okay, this is psych and this is not general medicine, but I'm looking at the back of his head and the back of his head was huge and he was a big kid. And I was like, it seems like his growth hormone might be out of whack. And I was listening to the mom talk about how the kind of mental parts of what he was doing he was acting out more and more. And I remember just being like, this sounds really to me like a pituitary tumor, because I had that basis of knowledge in somewhere in there. I didn't know everything about it. So I had to go back and look up the labs and look at those things. And I remember pulling his chart out and going through the whole chart and being like, oh, he has a very large pituitary tumor. And so I went to the doctor and I said, hey, I wonder how come he's not on any kind of medications for this pituitary tumor. And the doctor said, oh, I didn't know he had a pituitary tumor. Let's call his primary care provider and find out like what their plan is. And he made me call. And I was very nervous because I was like, what do I know? I'm the PA. I just reviewed the chart and I called. And the doctor said that he had never gotten those test results. And I just remember thinking, one, that general knowledge was so important. So even if I go into a specialty, I'm always going to be involved in my patient care. And that's why my visits are long, because I go into that stuff. But I think it also made me recognize that sometimes in medicine, we all get super busy. And sometimes those kind of things don't get followed up on. And it takes a team. Even if it's the student in the room, it takes a team of everybody coming together and saying, hey, patient care doesn't just stop at whatever is in that room. And we don't always have time for that. But it's been the one thing that anytime that kind of trigger goes off in my mind, I go back to the chart and I go and I look things up and I figure out what's going on and just make sure that loops have been closed. And I think for me, it was a really good reminder of just the extra effort that you put into patient care. And so I think that's part of what's made me be the PA that I am today.
Jenny Fayette, thank you so much for being on the podcast today.
Yeah, thank you for having me. I appreciate it.
Thank you, listeners. If you like what you heard, please subscribe, rate, and review us. To contact me, email rep.andrew.gray@akleg.gov or call my office at 907-269-0123.